If your doctor has already told you your testosterone is normal and you still feel the way you feel, that result is not a reassurance. It is a data gap. And the gap has a very specific cause. The standard testosterone test that most men receive is not designed to answer the question you are actually asking. It is designed to rule out a disease. You do not have a disease. You have a system running below the baseline it is capable of. And that distinction requires a different instrument entirely. This video is about that instrument, specifically 9 biomarkers, what each one reveals, and how to walk into that appointment and ask for them in a way that produces a real conversation instead of a number that ends one. Here is what is actually happening when your doctor orders a testosterone test. The standard panel measures total testosterone, one number, one draw, compared against a reference range that was built from a population that includes sedentary men, men in poor metabolic health, and men 20 years older than you. When your number lands inside that range, the result reads normal. The conversation ends. The problem is not the number. The problem is what the number is not measuring. Total testosterone is the gross figure. It tells you how much testosterone your body produced. It does not tell you how much of it is available to do anything. Here is why that distinction matters. A significant portion of testosterone in circulation is bound to a protein called sex hormone-binding globulin, SHBG. Bound testosterone is inactive. It is testosterone your body manufactured and then locked in a storage unit with no key. The number on your lab report counts it anyway. The most dangerous lab result for a man in this situation is not a low number. It is a normal number that ends the conversation. There is a second structural problem. Men in sustained high-performance roles run chronically elevated cortisol. That is not a diagnosis. It is a job description. The biochemical consequence of chronic cortisol elevation is a well-documented process called the pregnenolone steal. Cortisol and testosterone share a precursor hormone. When the body is allocating resources toward a chronic stress response, testosterone production is one of the first things it trades away. This process does not show up on a total testosterone draw. It shows up in a pattern across multiple markers that the standard panel was never designed to capture. A third problem: the reference range itself. Normal in the context of a standard lab is a statistical term. It means within 2 standard deviations of the population mean. It does not mean optimal. It does not mean performing at the level your system is capable of. It means not diseased. These are not the same conversation. And the man who leaves the office with a normal result and a still unresolved symptom pattern has been answered with the wrong question's answer. So let's talk about what actually matters. Here are the 9 markers worth requesting, and why each one comes times 1. Free testosterone. This is the number that actually matters. Free testosterone is the fraction not bound to SHBG, the testosterone available to act on tissue, cognition, and drive. A man can have total testosterone at the middle of the reference range and free testosterone at the bottom of it. Standard panels do not include this. You have to ask. 2. SHBG, sex hormone-binding globulins. This is the binding protein. Elevated SHBG is common in men over 40, particularly those with high metabolic demand and chronic stress exposure. When SHBG is high, more testosterone is locked out of circulation, regardless of what the total number shows. You cannot interpret free testosterone without knowing SHBG. They are the same question asked twice. 3. LH. Luteinizing hormone is the signal the brain sends to the testes to produce testosterone. If LH is low and testosterone is low, the problem originates upstream in the hypothalamic pituitary axis, not in the testes themselves. If LH is high and testosterone is still low, the testes are receiving the signal and not responding. 2 different mechanisms, 2 different interventions. Total testosterone tells you neither. How many of these has any doctor proactively ordered for you? If the answer is fewer than 3, the conversation in that office has not yet begun. 4. Cortisol. Ideally a 4-point diurnal panel. A single morning cortisol draw gives you 1 data point on a curve that moves significantly across the day. What you want to know is the pattern, specifically whether cortisol is elevated in the evening, which is the pattern most associated with fragmented sleep and the 3 a.m. wake-up that a significant portion of men in this situation know exactly. A 4-point saliva panel maps the curve. A single serum draw at 8 a.m. does not. NOx5, DHEAS, dehydroepiandrosterone sulfate. Narx is a precursor hormone produced by the adrenal glands. It declines with age and declines faster under chronic stress. Low DHEAS is associated with accelerated biological aging, reduced stress resilience, and directly relevant here, further suppression of testosterone production. It is also one of the first markers to move when adrenal function is compromised. It rarely appears on standard panels. It takes 20 seconds to add to the order. Number 6. Estradiol. Specifically sensitive estradiol, testosterone and estrogen exist in a ratio. In men over 40, particularly those carrying excess visceral fat, aromatase enzyme activity converts testosterone to estradiol at an accelerated rate. Elevated estradiol in men is associated with reduced libido, increased body fat, mood changes, and fatigue, a symptom profile that looks, from the outside, almost identical to low testosterone. The treatment is not the same. You need the number. And it needs to be the sensitive assay, not the standard estradiol test built for female reference ranges, which is what most labs will run if you don't specify. 7. Prolactin suppresses the hypothalamic pituitary gonadal axis, the entire hormonal communication chain from brain to testes. Chronically elevated stress, certain medications, and occasionally a small pituitary adenoma will raise prolactin and produce a testosterone suppression pattern that no amount of lifestyle intervention will reverse. It is not common, but the test takes 30 seconds to add, and the consequence of missing it is significant. 8. Thyroid panel, TSH, free T3, free T4. Thyroid function and testosterone function are not the same system, but they produce symptoms so similar that an undetected thyroid issue will consistently be misread as a hormone problem. And a testosterone protocol built on that misread will not hold. The cognitive blunting, the fatigue, the cold intolerance, the slow recovery from training. These can be thyroid. They can be testosterone. They can be both. You cannot treat the right system without measuring both. HBG9. Fasting insulin and HbA1c. HBG9 insulin resistance is one of the strongest suppressors of testosterone production in men over 40 and one of the least discussed. Visceral fat drives aromatase activity. Insulin resistance drives visceral fat. The hormonal decline and the metabolic picture are the same cascade, operating at different layers. HbA1c gives you a 90-day average of blood glucose regulation. Fasting insulin gives you the early signal, years before HbA1c moves. If your doctor is not measuring both, they are watching the river without measuring the rain. Now, how to actually have this conversation. The challenge most men face in this appointment is not the medicine. It is the optics. Walking in with a list of tests you found online reads, to most physicians, as either anxiety or WebMD. Neither produces the response you need. Here is a different frame. You are not asking for tests. You are presenting a clinical case. Your clinical case with a specific symptom pattern, a plausible mechanism, and a request for the data that would confirm or rule it out. The opening language matters, not, I've been reading about testosterone and I want to check my levels. That is a patient asking for something they found online. Instead, something closer to this. I've had a progressive pattern of fatigue, cognitive blunting, and sleep disruption over the past 18 to 24 months. I'd like to run a more complete hormone panel, specifically including free testosterone, SHBG, LH, sensitive estradiol, DHEAS, prolactin, a 4-point cortisol if possible, and thyroid function including free T3 and T4. I want to establish a baseline before drawing any conclusions. That is not a layman asking for things he doesn't understand. That is a man presenting a symptom history and requesting the data set that would allow a clinical assessment. Those are meaningfully different conversations. What if the doctor pushes back? The most common response is, your total testosterone is normal. You now know the exact follow-up. I understand the total is within range. I'd like to know the free testosterone and the SHBG because I want to understand how much is actually bioavailable. Can we add those to the order? That is one sentence. It is not a confrontation. It is a request for a more complete data set, which is a reasonable clinical ask that a physician comfortable with hormone medicine will recognize immediately. If the physician declines the full panel and you cannot navigate it, you have two options. 1. A private lab draw. Direct-to-consumer hormone panels exist specifically for this situation. They cost less than most people expect. and they do not require a physician's order. 2. A referral to an endocrinologist or a men's health specialist, which your primary care physician can provide, and which resets the conversation with the clinician whose primary practice is exactly this. The point is this: this is not a conversation about asking for things. It is a conversation about presenting a clinical case, your clinical case, with enough precision that the appropriate response is to run the data. The man who walks into that room prepared is not a patient being managed. He is a professional, gathering the information he needs to make a decision. That is a frame you have operated in every day of your career. It applies here with exactly the same discipline. If you want to bring something into that appointment, rather than reconstructing this from memory, there is a resource in the description built specifically for this. It maps all 9 markers, the optimal ranges for men in sustained performance roles, and the exact language framework for the consultation. It is the brief for the meeting. Link is in the description and in the pinned comment. When the results come back, and they will look different from what you've seen before, here is how to read what you're looking at. First, separate the reference range column from the optimal range. These are not the same document. The reference range tells you whether you are statistically abnormal. The optimal range, which your lab report will not include, tells you whether you are operating at the level your system is capable of. For free testosterone, the reference range bottom for men is roughly 35 picograms per milliliter. Men reporting full cognitive and physical performance typically run between 100 and 150. A man at 40 picograms per milliliter is technically normal. He is also running at less than half the baseline associated with the function he is trying to recover. For SHBG, elevated levels, typically above 45 to 50 nanomoles per liter, are common in men with high cortisol exposure and low-carbohydrate dietary patterns. Elevated SHBG is not a permanent state. It is a system response to specific inputs, and those inputs can be changed. For cortisol, the pattern matters more than any single number. What you are looking for is whether the curve is flat when it should be declining, or elevated in the evening window. Specifically, the 10 p.m. to midnight range, which is the pattern most directly associated with the sleep fragmentation this audience knows well. For estradiol, in men, the optimal range sits between roughly 20 and 30 picograms per milliliter. Above 35, the symptoms of estrogen excess begin to overlap significantly with low testosterone. Below 15, bone density, mood, and cardiovascular markers are the concern. The number matters. The direction it needs to move is determined by where it sits. For thyroid, free T3 is the active form. TSH alone, which is all most standard panels include, is an upstream signal with a significant lag. A man can have TSH within range and free T3 low enough to account for everything he is experiencing. Without free T3, the thyroid picture is incomplete. For fasting insulin, anything above 10 micro-IU per milliliter in a fasting state indicates early insulin resistance, years before blood glucose rises enough to flag on an HbA1c. This is the early signal. This is the lever that moves before the others become necessary. What you are building with these 9 numbers is not a diagnosis, it is a baseline. A baseline tells you which layer of the system is under the most pressure. It tells you which lever to pull first. And it tells you 6 months from now whether the input you changed moved the number, which is a different kind of certainty than the one you've been operating on. The man who has this data is not the man who had a doctor visit. He is the man who now has a map of a system he was previously managing blind. The guide in the description takes everything in this video and puts it into a single document you can bring to that appointment. Optimal ranges, conversation framework, and all 9 markers in order. Link is in the description and in the pinned comment. If you've already had blood work done and been told everything is normal, what did they actually test? What you now have that you didn't have at the beginning of this video is the difference between a test and a panel. A test answers a single question with a binary result. Normal. Not normal. The conversation ends. A panel maps a system. It tells you which layer is under pressure, which mechanism is producing the symptoms, and which input is the first lever worth pulling. That is not a small distinction. It is the difference between a data point and a diagnosis you can work with. The 9 markers in this video exist on a single requisition form. Most of them are covered by standard insurance. All of them can be ordered in one appointment. The appointment itself, framed the way this video framed it, takes less preparation than any professional meeting you have walked into in the last decade. The result that ended the conversation before ended it because it was the answer to the wrong question. Is your total testosterone within the population range is not the question. Is your system producing, binding, converting, and utilizing testosterone at a level consistent with the function you are trying to recover? That is the question. You now have the instrument to ask it. One thing to do this week. Not eventually. Book the appointment. Bring the panel. Ask for the data, not the result that ends the conversation. The data set that begins it. The man who has this baseline is not further along in a decline. He is the man who stopped being managed by a system that was never measuring what actually mattered and started managing it himself. That is not the beginning of a protocol. It is the beginning of a different relationship with a system that has been running without your input for longer than it should have. The liver is in the description. The rest of the system follows from it.